Welcome to the Assessing and Intervening in the Home with Victims of Intimate Partner Violence webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question and answer session. At that time, if you have a question, please press the 1 followed by the 4 on your telephone. If you'd like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Tuesday, June 7, 2011. I would now like to turn the conference over to Amanda Hopping-Wynn, Project Analyst. Please go ahead.
Hello, and welcome to the Kickoff Teleconference in our 2011 series. I'm Amanda Hopping-Wynn, Project Analyst of the National Abandoned Infants Assistance Resource Center, located at the University of California at Berkeley. Funded by Health and Human Services Children's Bureau, our mission here at AIA is to enhance the quality of social and health services delivered to children and families affected by substance abuse and/or HIV, by providing quality training, information, and resources to the professionals who work directly with these families. On behalf of the Resource Center, I would like to welcome all of you to today's teleconference training on assessing and intervening in the home with victims of intimate partner violence, with Dr. Phyllis and Dr. Carla S. Dr. Phyllis is an expert in maternal and child health nursing, a researcher and a mentor to the next generation of Johns Hopkins nurses. In addition to serving as chair of the Johns Hopkins University School of Nursing Department of Community Public Health, she is also the director of 3 health and wellness centers operated by the school, provides care in a Baltimore shelter for homeless, battered women and their children, and conducts ongoing community-based participatory research. With a $3.5 million grant from the National Institute of Health, Dr. Sharps is testing the Domestic Violence Enhanced Visitation Program, or DOVE, a promising intervention to keep abused women and babies safe from intimate partner violence. Dr. Carla Smith-Stover is a licensed clinical psychologist and assistant professor at the Yale University Child Study Center. She has extensive clinical experience with families impacted by domestic violence, including police mental health collaboration, early intervention, and longer-term evidence-based treatments, including trauma-focused cognitive behavioral therapy and child-parent psychotherapy. She conducts program evaluation research on engagement and treatment strategies for children and families exposed to trauma and domestic violence. Before we continue, I'd like to review a few important administrative details. To eliminate disruptive background noise, only the presenter's lines will be open throughout the entire call. If you need individual operator assistance, dial *0 at any time. Your discussion with the operator will not be audible to participants. If at any time you have questions for the speakers, please write your questions in the chat box located on the bottom left-hand side of the screen and send to chairperson. For those of you who are participating by telephone only, there will be 3 times during the presentation when you may also call in with your question. Once prompted, press 1-4 on your phone to be placed in line. If at any time during the training you're disconnected, please just dial in again. You can be reconnected at any time without interrupting the proceedings. If you encounter any problems with the web portion of the call, please jot down your problem in the chat box located on that bottom left-hand side of the screen, and a ReadyTalk representative will assist you. There will be participant polls scattered throughout the presentation. When you see a slide with a poll on it, please choose your answer and press Submit. Participants will then see a bar graph with real-time responses. We value your feedback and would appreciate it if you complete a brief online evaluation after the teleconference. It will automatically appear on your screen after the end of the webinar. And at this point, I'd like to turn the call over to our first presenter, Dr. Phyllis Sharp.
Good afternoon, and thank you for joining the call. I'm going to talk to you about a research project we are implementing in Baltimore City and rural Missouri and also St. Louis. But first, I would like to give you a little bit of background on definitions or how I perceive and understand intimate partner violence. The CDC definition suggests that it's physical and sexual violence, and also the threat. Important keywords are threat, coercive tactics in the context of physical and sexual violence, and it can be performed by a spouse, an ex-spouse, boyfriend, girlfriend, or ex-boyfriend, girlfriend, so any intimate partner violence. The World Health Organization has a more broad and general definition that suggests that it is any type of behavior by any person in an intimate relationship relationship that causes physical or sexual harm, and it includes behaviors that are physical, psychological, forced, and other forms of sexual abuse. So those are the context that when I talk about intimate partner violence, that it is performed inside of a relationship and an intimate partner or ex-partner. So by background, nurses in the public health arena have always been involved in home visiting, and we believe that nurses in the perinatal setting have been very useful in helping to reduce the risk of poor pregnancy outcomes, improving parenting skills, and also assisting mothers to enhance infant development. And most people are aware that David Old's program, the Nurse-Family Partnership, is one of the premier programs and has been shown most effective in reducing risk for child maltreatment. However, not as effective for reducing risk related to family violence. Generally, home visiting programs in the perinatal period have in common, regardless of different protocols and different approaches, but typically they provide anticipatory guidance to parents. They usually have a specific curriculum to enhance parenting or other aspects of child development. They generally provide social support and practical assistance to parents and caregivers, and getting parents hooked up with appropriate community resources. Home visiting programs during the perinatal period use a variety of home visitors. They can be nurses, they can be lay or peer visitors, social workers, health educators, or any combination of these types of visitors. The DOVE project, which I'm going to talk about, DOVE is an acronym for Domestic Violence Enhanced Home Visitation. We affectionately call it DOVE, and Amanda has informed you that it is funded by NIH, and we are finishing the 5-year project. So we set out to combine 2 evidence-based interventions to test, I'm sorry, I skipped a slide. There we go. We wanted to use public health nursing home visitation to specifically address intimate partner violence among pregnant women and to improve pregnancy outcomes and postpartum outcomes for women, their unborn babies, and their infants. We use a very specific protocol to address the partner violence, a brochure. We delivered the specific protocol at 3 different times during the pregnancy period and 3 different times during the postpartum period. The intervention ended at 4 weeks postpartum. We combined 2 evidence-based protocols, structured intimate partner violence based on Parker, and public health home visiting, of which data from CDC, Dr. Hahn provided a great deal of evidence that home visiting does have positive outcomes for pregnant women. Our goal was to determine whether DOVE could be effective and could be integrated into existing public health and postpartum home visit programs. We also, because the study is implemented in rural areas in Missouri and urban settings in Baltimore and St. Louis, we wanted to look at whether there are differences in patterns of abuse in different settings, and also whether this home visiting could be effective in reducing the effects of exposure to partner violence for pregnant women and their children. Our model was based on providing information to mothers to increase their awareness of partner violence and its effect on pregnancy and children, to discuss options to keep them and their babies safe, and to discuss child development. We aim to enhance maternal skills related to parenting and getting them hooked up with resources, and also instituting a safety plan and safety behaviors. We aim to do this through empowering mothers to make decisions and solve problems. We hoped, in terms of outcomes, that mothers would report decreased frequency and severity of the violence, that they would report increased use of safety behaviors to keep them and themselves and their babies safe, as well as increased use of community resources, that they would report improved physical health and mental health, including less depression and better self-esteem and less stress around parenting. And for the babies, we hope that they would have less exposure to partner violence and improved physical health and growth and development. This is just a process of how we receive referrals from the health department. Those came into the maternal and infant program, and then the health department made a referral to the research team. Women were eligible if they had a history of partner violence within the year before pregnancy or the current pregnancy, if they were less than 31 weeks of pregnancy, and they were over the age of 18. We then contacted them if they agreed per the research protocol and all of the IRB things they were enrolled. In Missouri, the process was a little different. We had 12 health departments. 6 were randomized to deliver the Dove intervention, and the other 6 did whatever was their usual care. So, does Dove work? We have been able to look at preliminary data for the first 230 women in the sample at birth and at 18 months after birth. And basically, I would like to call your attention, and this slide looks at, wow, I'm pretty fast. I keep skipping slides. I think they're a little reversed. Okay, the first one is mental health, and as you can see, I'm sorry, the first slide looks at violence, and as you can see, if you look at the third column under Dove, at delivery, you can see that there was a significant drop in self-report of violence, the conflict tactic scale, and it dropped even further at 18 months. If you look also at usual care, you can see that their score of 30 is below what they reported, but higher than the Dove intervention group. The same thing if you look at the severity of violence against women scale. Both mothers reported a drop, but a significant higher drop in self-reported violence for women that had the Dove intervention compared to usual care. Interestingly, if we look at the depression scores, and I think the slides are mislabeled, but the second slide is the depression score, the Edinburgh postpartum depression, and the self-esteem. Both groups reported less of depression and more self-esteem, but the trend in the data shows that the Dove mothers had a lower level of depressive symptoms, so they're not symptomatic of depression and higher self-esteem. So why do we think Dove works? We think it is a 10-minute intervention that can be integrated into an existing home visit protocol. It allows women to talk about what's happening to them. There is a specific protocol that we address what's happening to them, and we follow up on 6 different visits to see if the safety plan that they developed is working and what other resources that they would need to implement their safety plan and be connected to resources. And we are pleased. We are finishing up data and should have final reports in by the end of the year. And at this point, I believe I will be turning it over to Amanda.
Thank you, Dr. Sharp. Participants, I'd like to ask you to hold your questions until the completion of Dr. Stover's presentation. And at this point, I would like to turn it over to Dr. Stover.
Good afternoon, or I guess morning on the West Coast. Thanks for joining the call. I thought, weren't we going to do a poll question first, Amanda?
and answer yes, no, and then click the submit button. Okay, Carla, it's all you. It looks like 60% of participants do have a relationship with their local police department.
Oh, that's terrific. I'm actually glad to hear that because what I'm going to be talking with you about today is our domestic violence home visit intervention project here at the Yale Child Study Center. It's part of our Child Development Community Policing Program that is a partnership with the New Haven Police Department here in New Haven, Connecticut, and the Yale Child Study Center. And the CDCP program has been replicated in many locations around the country, so some of you may be familiar with the police mental health partnership that I'm going to talk about, but this protocol in particular is specific to the work related to cases of domestic violence that are reported to the police department. And so cases are identified by the police for a home visit, and what happens is there's an advocate, domestic violence advocate officer teams make unannounced visits to the homes of women who have had an incident of domestic violence, and paying particular attention to cases where we know or we think that children are in the home. The visits take place within 72 hours of the domestic incident, and the idea is to really try to engage women through community-based outreach, to use officers who have been personally assigned to cases, who are familiar with the neighborhoods where the victims live. In terms of community policing, officers tend to be assigned to a specific neighborhood and get to know the people in the community well, and so they may even already have a relationship with the family or woman that we're going to visit. And then the focus is on concern for the children, to really do a safety check, and concern for the family, concern for children that might be in the home as a way of trying to engage. So some just sort of quick nuts and bolts of the home visit outreach. What happens is that, as I said, the visits are unannounced, and so the officer and advocate will go to the resident, and the officer will knock on the door and will introduce the visit as a regular part of their police protocol. So it's sort of standard after there's been an incident of domestic violence in which the police were called. They'll reference the specific incident that happened the day before or a couple of days before, and it's really part of their community policing program. And then what follows is really trying to engage the woman, the victim or survivor, about safety assessment. What are their risks, what are their concerns, and trying to engage them around assessment. Do they have concerns about their children? Leaving some psychoeducational information about children's exposure to violence, and then allowing for flexible follow-up. So if a woman is not interested in any further follow-up, if she sort of opens the door and says thanks but no thanks, then they might leave some written information if she likes and then leave, or they can come back for multiple visits if she chooses to have further contact, either with the officer and the advocate together, the officer alone, or the advocate alone. And so then what I'm going to tell you a little bit about is some evaluation of the program that we did over the preceding few years. And so this is just to show you, to give you an idea of the kind of services that were provided at the time of the home visit. So this is a sample of 300 cases that were referred. So again, these weren't participants who were seeking out services per se. These were 300 cases that the police identified, that the teams went out and made these unannounced visits. They were able to make contact with almost 70% of those families. And you can see the red bar is that really the visits typically involve safety planning. There's just a couple of cases where that didn't happen, and that's really when a participant just doesn't even want to talk to the team at all. But most of the visits, they received safety planning, legal services, which was really partially an explanation of the protective order, what the women could anticipate in court, kind of legal services might be available to them. And then psychoeducation was what I was talking about before, really providing them some information about the impact of domestic violence on their children, talking to them a little bit about how they were doing, if they were having any symptoms or difficulties, and leaving some written information. And then in a smaller number of cases, providing crisis mental health, at the time of the visit or afterwards. Police services with things like enhanced police coming by, driving by the house more regularly for victims who were quite frightened of the perpetrator coming back. And then the purple bar there is the follow-up, and we had about a little over 30% of participants who actually wanted follow-up from the team, and we felt that given this was sort of an unannounced, unsolicited outreach, that was actually a pretty good response of recruited 100 participants to be interviewed 3 times, once immediately following the incident, but once immediately following their domestic incident. 50 of them received the domestic violence home visit outreach, and 50 did not. They just received the police response, standard police response without the follow-up visit. And basically what we found is that women who received the domestic violence home visit intervention really felt much more respected by the police. They had an overall interaction with the police that was more positive. They reported feeling safer after the intervention than those that did not receive the follow-up visit. And they were really overwhelmingly positive about it. We weren't sure when we did this survey if the participants would like it, if they didn't want to be bothered, didn't want the service, and 92% really were quite positive about the intervention. In terms of safety, about 64% of the victims felt safer after the intervention, and victims were asked to rate the officers and advocates as well, so we could get a sense of their feelings about the partners in the intervention, and 80% felt the officers did an average or above job, and 92% felt the advocates did an average or above job. So they felt that they were helped by the service in some way. 91% said they would call the police again, and 84% said they would call the advocate if they needed help. So this is to show you, so participants were interviewed. We followed these participants, the 100 that I mentioned, over 12 months, and we were interested in recidivism, so repeat calls to the police for domestic violence, and we were also interested in their engagement in services. So women who received the domestic violence home visit intervention, you can see from the blue bar, they were more likely to report a repeat incident of violence, so they were more likely to call the police again. But what we looked at was then also the severity of those charges, because we knew that the women were more comfortable with the police and said they were more likely to call the police again than women who didn't get the outreach visit. And so the red bar, you can see that the domestic violence home visit group were calling more for less severe kinds of incidents. So they were calling for more incidents of verbal violence, or if there was a violation of the protective order. So the charges for the subsequent cases were for breach of peace, or they were really calling about violations of protective order, whereas the control group were calling for more incidents of physical contact, physical violence kinds of incidents. And then the last part of the evaluation was about whether they were engaging in services. So part of the other piece of the visit is that the advocates were trying to help women get connected with services, mental health services that they may need. And what we see is the red bar is the domestic violence home visit intervention, and the blue is control, and the yellow is just the domestic violence services that we have here in Greater New Haven. And as you can see, that the domestic violence home visit group really was much more likely to engage in mental health treatment for their children. So we were successful in helping them get their children hooked up with needed services, assessments, and treatment as needed. Interestingly, I don't have a slide for this, but we weren't more successful in getting the women more engaged in mental health services. That didn't pan out, but the engagement around their children was successful. So the last slide here, what we thought this means is we felt like this meant that the DVHBI really opens the door to helping families affected by domestic violence, that it enhances the police-victim relationship so that they may feel more comfortable contacting the police and be more likely to reach out to the police in times of need. We found this to be particularly true for Hispanic victims, and we really, I didn't mention this before, but we did, when there was a Spanish-speaking family, we would send out a Spanish-speaking officer advocate team, and so we had that language capacity here, and that really increased engagement with the team if they were a Spanish, both the officer and the advocate were Spanish-speaking. We also found that women didn't necessarily want assistance on our schedule, and so women who were involved in the research project, we had research assistants who were constantly reaching out to them by phone, and we found that toward the end of the research project, women who were engaged were asking the research assistants to be reconnected with their advocate, or that they wanted to then follow up with mental health services. And so we learned that perhaps continuing to follow up with families further out than a couple of days, even if they initially said they didn't want help, might be of benefit. So that's all I have.
Thank you, Dr. Stover. Operator, I'd like to open up the phone
Excellent. Ladies and gentlemen, to register a question over the phone lines, please press the 1 followed by the 4 on your telephone.
Also, for future polls, if you want to see the live response, you must either submit an answer or skip to results, and you'll see the responses in live time. Another note, the complete slides will be available on our website shortly, and we will keep you posted on that.
And ladies and gentlemen, as a reminder to register a question over the phone lines, please press the 1 followed by the 4. And we have a question from the line of Christine Ayan. Please proceed.
Hi, I was wondering if you could give me a little bit more information about the percentages entering treatment slide. When it said percentage of DV cases in treatment, this was the kids, I'm understanding.
Yes.
You know, there was a higher percentage of people who had received the intervention, getting their kids into treatment, lower percentage of the control group. But I missed or didn't understand what the bar about the DV services.
Oh, okay, I'm sorry, yes. So we were interested in, we have the domestic violence services of Greater New Haven sort of accept calls from, all around our catchment area for women calling for various reasons to the domestic violence services. And this just shows the percentage of women who were seeking and engaging in services for their children from that service. Because other than our outreach service, it's really the main way that women who have domestic violence issues access service.
Right. So this was part of this yellow bar would represent people that had received the intervention who called the DV services.
No, this was just data from their website indicating
just people in general.
Yes, the percentage of their callers who they had connected up with child-related services.
Oh, I see. Okay.
Yep.
Thank you.
You're welcome.
Our next question comes from the line of Rose George. Please proceed.
Good morning. My question is in response to the DOVE program. If Dr. Sharp could speak to maybe some of the psychosocial intervention that maybe women had that enhanced their successes, and if there was any type of psychosocial support provided to women, if maybe what that was.
Yes, thank you for the call. I think that when we did the discussion about intimate partner violence and what it was, we talked about outcomes in terms of depression, anxiety, low self-esteem, the impact upon pregnancy. We also were screening for depression, and so women that were symptomatic, we were sure that their home visitor was also aware, and we also assisted them. The Dove nurse, home intervention nurse, made referrals and got them connected. So part of the psychosocial was helping them to understand that depression may have been related to the experience of violence and trying to normalize it, and then also making referrals to appropriate agencies. And then checking back to be sure that they had indeed contacted those agencies.
Okay, thank you.
We have a write-in question for Dr. Stover. The question comes from Alicia McQueeston, and it is, in your experience, how receptive were the police officers to the DV home visit intervention program, and did they have any specific training?
Yes, thank you. That's a great question. They did, in fact, have specific training. We conducted training. We do training yearly with the New Haven Police here related to children's exposure to violence, the impacts of domestic violence, engaging with victims and their children. And so they did have specific training. And I think that, in all honesty, the reception is mixed, and that some of the officers were really interested in doing that. And so as the program got going, we were able to identify specific officers that had a passion for this kind of work, and they really thought it was important. And so those were the officers that were assigned to do these visits. And we found that when we, before we started the evaluation, we thought carefully about that as we were developing the program, and we found that if the visits were done by officers who weren't really that committed, they didn't go as well. And so it is, the officer that's selected is important, so it's a great question.
In the sake of time, we're now going to move into the interview portion of the webinar. We'll be accepting write-in questions throughout this section, and we'll open the phones at the end for call-in questions. Dr. Stover, how do you know who to assess for intimate partner violence?
Okay. I think that really the issue here is to think about that, intimate partner violence can happen to anyone, in all walks of life. We know that from the research data in terms of it happens to women from all socioeconomic classes, all ethnicities, all races. And so my feeling is that it's best, and it actually makes it more comfortable, I think, for service providers if assessing for intimate partner violence is a standard part of your initial assessment with a family or whoever it is that you're working with. And that way you become much more comfortable assessing for it because you're doing it all the time. And you also can introduce it as this is a standard part of our intake procedure or of our assessment procedure for our service. And I think that way you're assessing everybody, you're not making any assumptions, and then you also become much more skilled at doing it because it's a standard part of your work. So other than that, I would say, that sort of means you're assessing all comers, and I think you can't make assumptions too. I think it's also important not to always assume that victims are going to be women, because sometimes they aren't, or sometimes the violence is bidirectional, and that there's sort of violence within the family as a whole, and it's not just male to female, it's going both directions.
So you would assess all adults in the home?
Yes.
Dr. Sharps, would you have anything to add?
No, I agree with Carla that we cannot make assumptions, and it's important on how you frame the questions. And so we let our families know that this is something we asked all women and family members, if they're present, just to be so that they don't feel like we're singling them out or we suspect something or that kind of thing. So we support universal screening.
It sounds like it really normalizes it, which might help moving into the next question. How can you engage clients to open up about this issue? Dr. Stover?
Yeah. I think that really, like I said, I think the first part is that it's really a standard part of your practice, but then I think you really have to approach the topic without any set of ideas about what should happen, that you really want to listen to the victim or victims and learn about the nature of what's happening in their relationship, and not just about physical violence in particular, but what is their relationship like? What kinds of things do they argue about? How do the arguments proceed? When does aggression happen? Is it all physical? Because oftentimes the psychological and verbal aggression causes women more distress and more symptoms psychologically than the physical. They will report that they can deal with the physical. It's the verbal abuse that really gets to them. And so I think that you have to go into it with, an open mind, that you're listening, that you're not. I think often what happens when people first start assessing for IPV, they have this idea that they're going to identify it and they're going to, help these women leave. And often women don't want that. And so you have to go into it with the idea that you're going to find this out, and then it may be that she doesn't want to leave. And so if she thinks that that's what your goal is to identify that she has violence in a relationship and get her to leave her partner, she's less likely to talk to you about it. But if you're really approaching it as you want to understand what's happening in her family, you want to know as much as you can so you can provide the most support and help, then they're more likely to give you more information and talk with you about what's happening in their relationship if they know that you really just you want to hear their story and you're open to it.
Sure. I know our next question has been an interesting point for some of our listeners. Dr. Sharps, how might you handle a visit if the perpetrator is present?
Well, interesting that you asked that question, because as we do an extensive training of our home visitors to be able to implement the DUG, and part of it is a role play, and of course nobody ever likes role plays, but we typically have gentlemen as a part of the training audience, and so we surprisingly and unannounced to the home visitors in the role play, we have a gentleman enter the home who is, quote, the partner. What we do, because we are visiting pregnant and this protocol is also a part of the regular home visiting protocol. We have in our intervention bag materials related to parenting, fatherhood, and things that would be of interest to a man or the male partner. And we instruct our home visitors to quickly, if they're in the middle of the domestic violence protocol, to quickly shift and pull out those materials and engage the perpetrator in that. And that usually has worked very well for us. We also go over safety strategies for the home visitor and how to leave if that's necessary, but also assuring that the woman is safe and the family's safe.
Now, interestingly enough, it looks like about half of our listeners work with perpetrators, and about 50% don't. Dr. Stover, do you have anything to add?
I second what Dr. Sharp says. I think that having materials being open to engage the perpetrator is really important, because I think you don't, well, for one, you'll learn a lot about the person and the nature of what's happening. You'll get a first-hand sense from talking to him, engaging him, considering providing him information, as Dr. Sharp said, about fatherhood and his children. And my experience is, because I do a fair amount of work with perpetrators, is that fatherhood is really an area that you can engage these guys. And they are often very invested in their kids and interested in their kids, and they make bad choices, and they're not good partners sometimes. But this is an area where they can be engaged, and so I think you can find ways to include him in certain things, but certainly you want to have an opportunity to have a separate conversation with the victim about her safety and what kinds of information could or should or shouldn't be shared with him present.
And what about if young children are present in the home? How would you navigate assessment and intervention? Dr. Sharp?
Typically, and we've found this out in our clinical setting also, is that we do tell the mother there's going to be a time that we need to do some other physical assessments and talk to her about some other issues that probably the children should not hear, so that if there's someone else in the home that could entertain the children, we encourage that they do that, and they go to a separate place to do that. If that's not possible and women are able to read, what we often do is just to give them that part of the assessment and say, we would like you to answer these questions. And if she indicates that there are some issues about the children witnessing or being involved, then we will plan at either a separate time or a time when she's coming into the center for visit, or make a referral or that kind of thing to intervene with the children. But we really do not do that part of the assessment, not only with children, but other family members if that's possible, because sometimes there are, as obvious as it may seem to other people, there are things that she may not have talked to other family members about, and we want to make sure we maintain her privacy around those issues and safety around those issues as much as we can.
Dr. Stover?
Yeah, no, I would agree with that. I think the other thing that we've tried here on occasion when really there's a woman that we're particularly concerned about who has a fair number of young children who aren't in child care, she doesn't have anyone to help her watch the children when we come for the assessment where we need to meet with her alone, we will try to go in a pair, and I've done that before, like bring another clinician or an advocate, and we've gone out, and one of us will sort of do an assessment with the child, of course with the parent's permission, but play assess with the child while the other clinician or advocate is assessing the mom in a separate room.
This is Phyllis. Yes, we have also done that, and it does work very well.
Now, Phyllis, Dr. Sharp, you had mentioned the importance of not asking these questions in front of family members, and you both touched on this a little bit, but how do you create the privacy when you're in a home and anybody might be walking in and out?
I think it's something that becomes a skill of the home visitor who's watching and kind of assessing where all the family members are. Frequently in these homes, there's lots of background noise, and so that if you're able to sit close to the person, the mom that you're talking to, you can have a quiet conversation. Sometimes if she alerts you that the partner may be coming or not, we've worked out a code that allows us to know when we should shift the conversation, because we're always in there talking about her pregnancy health, so we can easily shift to something else. And when possible, we encourage the mother just to let the family know that she's talking to the nurse and there's going to be some health questions, or we might have to do an assessment, and she's going to go to another place so that folks are okay. I think we're fortunate in that, in general, nurses are very well received in the community, and so if someone says, I'm just talking to the nurse about my pregnancy or that kind of thing, it usually does not arouse a lot of suspicion. And, sometimes we may have papers to fill out, and we might say, well, we need to go to the kitchen because there's a table, and folks understand that, and that seems to work very well.
Now, Dr. Stover, you have a bit of a different situation since you're going in with police officers and not necessarily nurses. How do you create privacy?
Well, I think that it's a little different. The visits tend to be, we're not doing a lot of assessment usually at the time of the advocate officer outreach visits. Sometimes, depending on the nature of what happened. One of the things that has been successful is, at times the officer will introduce the visit, they'll talk for a bit together, and then the advocate will ask if the victim would like to talk separately. And if she does, then sometimes, as Dr. Sharp said, they may go into the kitchen and the officer will stay and talk a little bit with the kids, and because oftentimes the kids have been present, and so he's explaining to them a little bit about the police and what the police do, or the kids want to check out his nightstick or various things. And so the officers actually have been helpful sometimes in giving a little bit of privacy. At other times, really, the advocates would make a separate appointment at a time that's convenient to the woman to meet separately to talk about issues that she might have.
I'm going to invite participants to participate in our next poll while we move on. So we've talked a lot about assessment, and I'm wondering what the next step is. So what do you do if you discover that intimate partner violence is present in the home?
Is that for me?
Sure.
Okay. Well, I think the first thing is, as I mentioned before, is kind of going into it with an open mind and trying to hear what it is that the victim is wanting. But then to also, step one is also danger and risk assessment. How dangerous is this situation? Is there, should the victim be at heightened risk versus, if the violence is at a less severe level, there isn't really concern for very severe injury or things like that. And then after that, really trying to engage around psychoeducation, safety planning, trying to reduce continuing threat. Does she need help with restraining or protective orders? Does she want that? Are there other practical interventions? And then providing referrals. I think it's really important when you are in a home visiting program of any kind is that you really are familiar with the referrals and the other agencies in your community that can be of help. And so you can provide written information with referrals and contact information for those referrals, so that the woman can look back at those later. She may at the initial time that you talk with her, she may say she's not interested, but we found over and over that we leave sort of written materials or referral numbers, and then they'll use and contact those places weeks or months later. And so I think that that's another thing, is really having some materials that you can provide in written format.
Dr. Sharp, did you have anything to add to that?
Yeah, we do the same same thing, written materials. We have also magnets that really don't identify a specific number, but they are the numbers for the local hotline, the national hotline, and how to call the center. And I think absolutely what Carla has said, it's very important to assess the level of danger and risk, and also how she feels about her situation, and what she feels is necessary, kind of thing. And I think the open mind is very important. Particularly in pregnancy, we know that regardless to how severe what's happening or how frequent, most women are not thinking about leaving a partner during pregnancy. So the fact that we can talk to them about safety and referrals and other kinds of things that could be available to her actually helps. And we know eventually most of those women will leave, but it is a process, and there's something special and magical about pregnancy that many women think that somehow the baby in the pregnancy is going to make a difference, and unfortunately for many women it doesn't, and they may come to a different decision at a different time, but basically our role is to support and to keep them safe.
Now, interestingly enough, we did a poll while you were speaking, Dr. Sharp, to see who assesses for lethality and dangerousness, and about 45% of the respondents do assess for both, and 45% don't assess for either. I know it's very uncomfortable to ask people if they think their partner could potentially kill them. I mean, that's an uncomfortable position to be in. Do you have specific tools that you use to do that?
If you are asking me, Phyllis Sharp, we included some aspects of the danger assessment developed by my colleague, Dr. Jacqueline Campbell. And in fact, if people go to the Johns Hopkins School of Nursing website, they can actually click on to the danger assessment, or the Nursing Network on Violence Against Women. You can click on and download the danger assessment. And I think what's nice about it is it's kind of, you're having a conversation, and you can, you're asking about things, and maybe women haven't thought about these particular things that you're asking about as particularly dangerous, but as they begin to indicate more yeses, many women come to the realization that maybe I'm in a bad situation, and you know, and may want to think about something different. You're not, the way we use it clinically is we don't come up with a score and say, oh, you hit the magic score, and now you're in a dangerous situation. But women, I think, as you increase their awareness and talk about the items that are on the danger assessment, most women come to that realization, and that is often a helpful place to start an intervention, and a referral is when they also recognize that perhaps they should think about help and other options.
Dr. Stover?
I would agree. We also use the danger assessment scale that Dr. Campbell developed, and the same thing. We kind of do it in a conversational way, and we try to talk about what some of the issues are. And some of the items on there are not things that you would think of. You know, do you have a child that's not his? You know, I mean, it's not something that you would automatically think of as something that would increase risk, but it does.
Right. We have actually included some of these assessment tools in slides 38 through 45, which we can go through if we have some time after we open the line for questions. But I do want to make sure that our participants have ample time to ask both of you questions. So, operator, I'd like to open the phone lines now. And again, you would push 1-4 to be placed in line for questions. And if you're participating in the webinar portion, the online portion, you can type your questions in the chat box as well. Operator, are the lines open for questions?
Yes, and there's no one in the queue at this time.
Okay. Then what we'll do while we're waiting for questions, Phyllis, if you would like to scroll through some of these assessment tools that you've included, and then Carla, I'll ask you to do the
apologize. This is the operator. We do have a question.
Okay, proceed, please.
From the line of Christine Ayen. Please proceed with your question.
Thanks. So my question is, this presentation has looked at two types of intervention, one law enforcement based and then one public health based. I'm wondering if at some point during this presentation or even at the end, you could point to some resources where it's looking at intervention via child welfare workers, screening and assessment through child welfare in connection with an advocate. So, and I clearly see the partnerships that are set up here, but I'm particularly interested in resources that would be applicable to a child welfare and advocate partnership. And I can see how these would be transferable, but I just also wonder if there's anything specific that you know about. Can I clarify? This is Carla. Do you mean an advocate, domestic violence advocate, and child welfare workers?
Correct.
Yes. Okay.
This is Phyllis. I would have to defer because I'm pretty much a nurse and nurse home visiting and approach it from families and health rather than which takes in mothers and children rather than the child advocacy approach that you're talking about.
This is Carla. I can tell you in Connecticut, and I'm not heavily involved in this, but I can tell you what I know about it, is that the way we run our child welfare system here is that if a child protective services worker is aware of domestic violence or intimate partner violence in the home or is concerned about intimate partner violence in the home, there are specific domestic violence advocates that are actually employed by our Department of Child and Families, and they will come out and be the ones who assess and then try to engage around the issue of domestic violence. And I think that can work really well if there's a good partnership between the worker and the advocate. And I'm not sure if that's the kind of setup that you're thinking about, but I feel that it's really about the partnership, and that has to be strong. And it's not so much just the DCF worker is bringing you in as an advocate to do a job and not really kind of a partner in this idea of assessing and trying to figure out what's best for this family. I mean, certainly a domestic violence advocate has a specific skill set that the protective services worker may not, and so they could really be a strong partner, I think, but I think it really takes developing relationships and working closely, each agency working closely together to make that work well.
And in addition, this is Amanda from the AIA Resource Center. I just wanted to let you know that we will be holding a 2-day skills building training, September 21st and 22nd, which would give you the hands-on clinical tools to assess and intervene in the home with intimate partner violence. And this is for nurses, this is for child welfare workers, this is for nonprofits, so that might be of interest to you as well. And you can find information for that on our website, www.aia.berkeley.edu.
This is Carla. I want to add one other thing. There's also a lot of resources on the National Child Traumatic Stress Network website, if people aren't familiar with that. And there is a child trauma toolkit that is specifically for child welfare workers that it assesses child trauma broadly, but I believe there's some specific things in there for assessing intimate partner violence that are part of a whole package, and it's a really comprehensive and nice package. And the website for that is www.nctsn.org. And there's actually a lot of information on that website about domestic violence as well.
Operator, are there any other questions on the phone?
Not at this time.
Okay. So back to the abuse assessment screen.
Yes, this is one that I put the website link where you can download it. What I like about this assessment is very simple, and it asks about direct behavior. I find that to ask about specific behavior you're going to get probably a better screen than to ask somebody about partner abuse or domestic violence or any of the kind of words that we like to use. Women understand things like hitting, slapping, pushing, and that kind of thing. And it's simple. It has been reproduced also in the March of Dimes module on training. It's a self-learning module on abuse during pregnancy. And it also has an intervention brochure that could be used based on the assessment, and you can personalize or individualize the brochure for your site. The next things are just kind of mnemonics that can be used if you don't have a specific tool, but things to kind of guide your assessment is that ask direct questions about specific types of behavior rather than kind of conceptual words that we use. Document the findings and avoid words like the patient alleges that. Just state, Mrs. Smith said that Mr. Smith hit her, or whatever the situation is. I also work in a shelter for domestic violence where we have women that are there, and our health assessment records have often been very helpful to women who are establishing custody or other kinds of issues. Always assess for safety and risk. Either refer someone if you don't feel comfortable about discussing options and safety planning, or you yourself do that. And I think follow-up is always important. And the assert tool is a similar kind of way of just a general assessment if you don't have a tool. I think the next series of slides are really related to how to frame questions so that you feel comfortable and that the women that you're screening or individuals that you're screening, I always alert people because usually my assessment is a part of health assessment, and just say the next series of questions I'm going to ask you are about your partner and your relationship. I ask them how I should refer to that person and put that name in. I always try to frame things so that they know, I'll say something like that. This is a problem for many women. We ask all the women that we care for. And I have to say that in the 20 or so years that I've been doing this, I've had very few women get upset because we ask these questions. So I think it's important to frame it and to let folks know. And also be comfortable that even though you may have a high index of suspicion, she may not disclose on the first time you ask. Women have to feel also safe and have some level of trust of what's going to happen to the information that she gives you.
I'm sorry to interrupt. We have a write-in question from Diane Javar, and she says, to what extent are controlling behaviors considered and addressed, such as a partner controlling access to money, transportation, phone, support, such as family or friends or work?
Those questions are usually a part of the danger assessment, and so if we get a screen that a woman is positive or indicates, then we will do a little bit more assessment to understand what the nature of the behavior is. Controlling, coercive, we look at stalking, we look at issues around children being used to intimidate women also.
Dr. Stover, do you have anything to add to that?
Yeah, I would agree. It's the same. We use the danger assessment also.
Okay, Dr. Sharp, continuing on. Sorry to interrupt you.
That's okay. So, these are just a series of questions. We like to try to cover things like verbal and emotional abuse, threats, stalking behavior. We've had women say that partners show up at the workplace, or partners leave notes on their cars, or that kind of calling and hanging up kind of behavior on the phone. So those are questions. We also asked about children, and again, if you're going to talk to her about children, this would be a time that you should do this in private, not around the children. As nurses, we also let women know that we are mandated reporters, so if they talk to us about abuse that hasn't been reported or is known to Child Protective Services, we will report that. We aim to do that with the women, and so it's not, we go back to the office and call. We try to work out resources in the Child Protective Agency so that we have generally specific people we call or try to talk to, but that this is something that we try to frame it so it's not we're out to get you or to punish you, but it's another way to get you services for your family. We've also found it's important to talk about medications and things that women might be doing to cope. So inappropriate use of over-the-counter medicines, use of prescription medicines. We're able to also show them, that smoking and drug use, alcohol, those kind of things are often related to her victimization and our ways that she is trying to cope. We also, not only do we assess for partner ideation around suicide, we also asked her, we know from research that often a partner that's thinking about suicide is thinking about suicide for himself, but probably doing some harm to the family. So that's a kind of a red light thing if we find that out. And I think that's the end of those series. And then this is part of the danger assessment. The danger assessment actually has about 20 items on it, but you're asking things about increase in frequency, increase in severity, specific behaviors like choking, threatening to hurt family members, use of a gun, partner lost his job recently, use of alcohol, all of things that don't cause violence but are associated with it and increase her risk for danger. And I think that's the end of that series of questions. Yeah.
Also, this is an additional resource for child welfare workers. If you go to the National Resource Center for Child Protective Services, which is nrccps.org, you can look under Special Initiatives and Domestic Violence, and you'll find many resources there developed in different states specifically for child welfare workers. And operator, are there any other questions on the phone right now?
No, not at this time.
Okay, well, I would like to thank our presenters, Dr. Stover and Dr. Sharps, for sharing their time. I'd also like to thank the participants on today's call and apologize for the technical difficulties which resulted in our late start. Now, the presenters have graciously offered their email addresses, so if you would like to contact them with further questions, you may do so. And if you have colleagues that would like to listen to the call, an audio recording and the slides will be on our website within the next 2 weeks. We do greatly value and seriously consider the feedback of everyone participating in these teleconferences, so a brief online evaluation form will appear shortly. If you could take a few minutes just to complete the form now, it'll automatically be sent back to us. We'd like to receive feedback from every participant, so if you're participating in this call as part of a group, please be sure that each member of the party receives the link to the evaluation. With that, thank you again to our presenters and to the rest of you for your participation. We hope that you found this to be a valuable experience and look forward to receiving your feedback. As a reminder, the next webinar training, Assessing for Fetal Alcohol Spectrum Disorders, is scheduled for July 13th at 10 a.m. In addition, if you'd like the chance for hands-on clinical learning on domestic violence, as I mentioned before, we're holding a skills-building training entitled Hope for the Future, Ending Domestic Violence in Families, which will be September 21st and 22nd, here by us in Berkeley with Alice LaViolette. So you can please see our website, www.aia.berkeley.